suture, in hurting. The only thing you can hit there is the superficial temporal artery or vein, and if you do, you just coagulate. And then I go down to the temporal bone, and I return laterally. Actually, this is the temporal vein here. And then I return backwards. Don't return anteriorly, because here you are about 2 centimeters in front of the helix, so return backwards. Now this suture is rock solid. I can lift patient's head from the table. That is very solid. That's why we place it on the temporal fascia. There was an older article about so-called S-lift by Ansari, and he says he fixated periosteum of the zygomatic arch. Now the periosteum is a 1 millimeter flimsy layer. How can you suspend the whole face on the periosteum? So we like this really rock solid fixation on the temporal fascia. And then we just take solid bites in the platysma, which is here above. It is the parotid fascia. It's like ½ centimeter deep. Also, if you do the surgery, every time you place a suture, if I place this in very heavy faces, if I place the suture just in the pad, too superficial, this will pull through. But if you place it in the fascia, this is very solid. And here, in this gentleman, we have already the platysma. Here, normally it can be a little bit lower. And the deeper I go in the platysma, the more effect I will have in the neck. And nowadays we have variations that we call the hockey stick suture. If we want to avoid opening the neck, we can go deeper and more medially up to the level of the premolars to have a more extended effect on the neck. So we can go, let's say this is our last bite in the platysma. And then we go back, and this is just a vertical U-shaped suture. Then, and you have your assistant, if you are working here in that little tunnel, you have your assistant pulling on this suture, so it brings in the tissue upwards. You see a little bit better. And then, this is absolutely safe with regard to the facial nerve. The facial nerve is deeper, especially so lateral. And then you end up in that little window that you made. There we are. And now you pull on that suture as much as you can. This is maximum traction. You have seen the effect in the neck. And if you pull on that suture, the whole neck is lifted upwards. And then you throw that suture 3, 4 knots, put a mosquito on that, and we continue immediately with the second suture. So we don't make 2 separate knots to prevent palpability of the knot. And now we just continue and we go more medially. Now this time in a more anterior, in a more open way, not as a narrow U-shaped suture. Also here, when you have done the liposuction before, that's what we do first, you can see that the platysma will be nice, cleaned, the fat will be away, and you can grab, you can take the lower stitches, you can grab the platysma, you are still above the mandibular border, and you just follow the borders of the endomine. Now you know the more medial you go, the more superficial the temporal nerve is, but you're still in a safe zone, which is ½ centimeter deep. This is, we had on more than 2,000 cases, we had 3 cases where we had entrapped a buccal branch here, and they all healed in about 6 weeks. So there is never a cut in the face, the only thing you can do, if you take a branch of the facial nerve in your suture, you can strangulate it and you have some neuropraxia. You never have a complete skin nerve section. And again, you end up in the window, and you pull on this suture, and then you see the effect on, you see the corners of the mouth are raising, and we are, so this knot, and good. And now you are in a situation that you will see some irregularities in the skin. Sometimes for the first time when you do that, it's frightening, it doesn't look good. But then you just take your scissors and you free the skin for 2 millimeters more, just what is necessary to have a nice, smooth surface on the cheek. And that's it. Now afterwards, sometimes in that second suture, you have a bulging of tissue and you have like too much, then you can just trim a little bit back in the lower part, because the lower part has to be sharp, and use that extra tissue in the upper part to make a little bit more augmentation of the zygomatic area. And then with a photomicro, you can suture, just very superficial, and suture this tissue upward and give a little bit more projection in the malar area. This is done with a running photomicro suture, and from here I go in the direction. Sometimes it's not necessary, but what is always necessary is that you close that little window with that suture, and you take some subcutaneous tissue and you just close that window so that the suture is not palpable. And that's it.